Well, welcome back to the Rehab Runway podcast. And we have a guest today, and not just a guest, but we have launched with a bang. So we've done a couple of solo episodes, and as I mentioned in the previous episodes, the plan was to invite amazing people on, pick their brain, learn from them, and also impart knowledge on to all our listeners. And what a guest we've got today. So we're fortunate enough to have Chris Johnson with us today. Now, Chris is a physical therapist, coach, and founder of Zeren PT and Performance in Seattle. Chris is one of the leading voices in running rehab, known for his practical, evidence-based approach to helping runners get back to doing what they love. He's a triathlete himself, a run triathlon coach, and someone who brings a brilliant mix of science, coaching, and real-world experience to the table. I've learned an incredible amount from Chris over the years, and so it was a pretty much a no-brainer as to one of the first persons that I invited on to talk. So welcome to the Rehab Runway, Chris, and it's nice to be on the other side of the mic. We've had chats on your podcast, but nice to be firing the questions at you today.
Yeah, well, it's an honor and privilege, and I'm really excited for you to start up this podcast. I think you're such a sensible voice, and you just have great energy and insight. So, I wish you the best of luck, but in your case, you're not going to need luck, man.
Thanks, mate. And one of the things that we're going to be talking about today is returning back from returning a runner back from injury. So it's going to be applicable for our runners themselves who might be listening, but also from our coaches, our health professionals that are listening to this that deal with runners. But just as a bit of a foray for those that don't know you, which I assume wouldn't be many, but a quick background on your work with runners that have led you into this niche and into this area.
Yeah, well, I think that, I ended up in this area out of having to navigate my own injuries. And, I didn't
Mm.
realize it at the time, but when I was around the age of 15, I had an OCD lesion in my knee, an osteochondritis dissecans, and I was told by a well-respected physician that I would never run again. And I did have a lot of my identity entangled in sport and athletics. That's how a lot of people knew me as, oh, Chris was, this athlete. And, I think that was the first time I really got derailed. But in hindsight, that put me on the path. And, I've dabbled in pretty much every sport in the book outside of football. My high school didn't have a football team. Um, but I've definitely gravitated towards running and triathlon during the latter half of my sporting career. And yeah, it's fun for me nowadays. I mean, I try to blend a lot of my own experience as an athlete, along with my coaching background and then reps that I've had in the clinic. So I'm in a good position to help people sort of troubleshoot or navigate their situation. And like everyone else, I'm still on the journey trying to learn and refine my craft.
Mm. Aren't we all? And that's one of the reasons why I've done this podcast to continue to learn from people like yourself. You mentioned there with that the injuries helped you learn, and I've certainly found the same thing as well too with managing my injuries. What do you think that's taught you, and the advantage that's given you as a clinician to have an injury and get through that, navigate that?
I think that I've learned through a lot of these injuries that, you have to really be patient. And, I think it's also helped me be a little bit more empathetic to people
Mm,
who are navigating this and not just looking at the injury. So
mm,
I'm literally about to release a newsletter talking about really understanding what's going on in the foreground when you're working with someone and then what's going on in the background. So what I mean by that is, when someone connects with you in consultation, they're there because of the stuff in the foreground. Hey, I
mm,
can't run. I'm having knee pain. This has pulled me away from something I enjoy doing. And I think that a lot of us, and I've been guilty of this and probably still am to an extent, is we're always trying to put that fire out. And that's a good
mm,
thing. We're trying to calm things down. But I think we also at some point need to understand the backdrop or the background of that person's situation,
mm,
because that's a huge driver. And I don't think people always get to that. And I think it's the analogy I use in the newsletter. It's like trying to blow out a trick candle, right?
yeah.
You think, okay, we have to calm down, and then you sort of have someone reintegrate, and then boom, there's another injury, right? And that can stem from incomplete rehab, but I'm always looking at the athlete holistically, and that's cliche to say, but it's one thing to talk about that and another, to do it, what that actually looks like. Um, so yeah, and I think that's really important.
Yeah, and you mentioned there that that cycle that can occur of injury into re-injury. What do you think is some of the common misconceptions that you see that runners and also other health professionals and coaches make in when it comes to returning from an injury?
I think if I could pin it to one thing, it's rushing to failure. It's
Mm,
trying to reintegrate back into training. And I put something up on Instagram recently saying, when someone is going through a healing process, I think as clinicians, we do a good job with physical preparedness, restoring
mm,
capacity, um, making sure that someone can withstand the performance demands of running. I think that there's also a mental aspect of healing where someone regains a confidence and they're willing. I know when someone's willing to take risks that, they have their confidence restored or it's approaching being restored. But, I also think there's a spiritual side of it, where
mm,
you move beyond having that injury become a part of your identity. You've
mm,
gone through it, you've learned from it, you can talk about it without getting sort of, choked up. And you really try and take your learnings and maybe channel them to someone on your team or a training partner. That's when I feel like, that healing process has been complete. So yeah, I feel like as I'm getting older that I'm getting a little bit more mystical or philosophical about all this stuff. But I
You're
think it
growing
helps.
the grey beard that of knowledge.
Yeah,
And
yeah,
you mentioned there that running, the runner that's their identity, and we do often see that, don't we? And what are some of the challenges that you see in that a runner is so focused on that's their life, and then they have this injury, and especially something like a long-term injury, like a bone stress injury. What are some of your things that you help them to work through that? Obviously, the rehab point of view, but then from a mental aspect, is that something that that your Jedi mind tricks or things that you're working on around that and the challenges they face?
yeah. I think if someone really has a challenging situation where there's sort of a mental bottleneck, I do think that people should not hesitate for a second to refer out to whether it's a
Mm,
mental health counselor, a psychologist, a psychiatrist. But I also, I feel like part of my responsibility is to channel energy and confidence to that person, because they've lost that. And above all else, they've become fearful. And they develop this fear that they're not going to get back to running. And
mm,
whatever is top of mind, it's funny how it tends to manifest. It's so fascinating to me where, I could be working with someone who has an advanced bone stress injury and they're able to make a pretty timely recovery. And then I have other people who this thing just drags on much longer than the healing time frames that have been put forth by Honig or Aurelia Native
mm,
or Kristen Pop. So I'm always trying to say, well, what's the difference there? And I think it's a thought process. Um, and I think that's ultimately what we need to get at. And that's a conversation to say, I sense there's this fear that's still present.
mm,
What do you think the source of that is? What are you afraid of losing through this process? Because I've seen a lot of people who, go through a very similar situation and they reclaim their lease on running. And I don't see anything that can get in the way of that with you.
mm,
So, but I think it's just broaching that conversation. And I
mm.
think sometimes clinicians are a little bit trepidatious about
Yeah.
talking about emotions. Like
Yes.
I have to deal
Yes.
with
Definitely.
emotions all the time. You too, with kid, with
Kids.
kids, with
Yeah.
friendships, with relationships. So,
Mm,
we're not trying to diagnose
no.
someone,
No.
but it's just sort of saying, does this person need help beyond just what I have to offer or, what my jurisdiction is?
Absolutely.
But I also think people read clinicians. They know if they're in the hands of someone who is caring, that is competent to help them. Like we give off vibrations, that
Mm,
sounds
mm.
like a lot of woo, but people sense this stuff and don't think for a second that they don't.
No, you mentioned that psychological readiness. That how do you balance between that the tissue recovery time? So say like a bone of this length or a muscle strain versus that readiness. Is that something that you're gauging? You're actually asking them, and is it getting near? How do you feel about this? You feel like you're ready to return?
Yeah, I mean, there are different scales that you can use, which I would encourage people, so long as that person is not rushing through filling out a form.
Yeah,
Like there's a brief resiliency scale, there's, the Tampa scale of kinesiophobia,
yeah.
there's a injury psychological readiness scale. So I think that you can leverage these, but I also think that you can just bring this up in conversation, and ask them like,
Mm,
do you feel like you're ready to
yeah.
sort of integrate back in? But you want to make sure that what you're seeing when you're working with that person in terms of movement, demeanor,
Mm,
disposition is lining up with what they're reporting subjectively.
yeah,
I have a
yeah.
lot of people that are like, yeah, I'm ready to run. And I'm
Mm,
like, you're not
they're not.
directly loading through the involved tissue or region. So I feel like they're going to take an altered, they're going to have some kind of compensation.
Yeah.
And that's when people go on. I've consulted a couple pros recently who had like plantar fasciopathy, for example, and they
Mm,
tried to reintegrate to running and they were loading their foot in an unaccustomed way. And they both developed fourth metatarsal stress fractures, not bone
mm,
stress injury,
mm,
grade 4 stress fractures. So,
mm.
um, yeah, so it's you're always sort of looking at things through different lenses to make sure that you're seeing a clear picture.
Yeah, yeah, and it is an interesting one. That sometimes and I've found too that when they're not, they don't feel like they're ready. There sometimes can be something that isn't quite right. That that you might be missing, or they just need a little bit more time to condition the tissues. But then sometimes things are ready, but they're just, again, they don't have the confidence in their body to be able to do it. So it can be sometimes hard to tease out which is which. I think we want to be able to trust our bodies, but sometimes, yeah, sometimes that process fails, doesn't it? That trust in our own bodies.
Yeah, and I think, you can talk to your patients and say, "Hey, this is what I'm seeing. What are you feeling? What are you
Mm,
experiencing,
mm,
as we take you through these drills?" And that just sort of gets both parties to lean in and have
mm,
a candid chat. I think a lot of runners they put a lot of pressure on themselves to plug back in, and it creates this anxiety. And I'm always
mm,
trying to just get them to radically let go and just say, when we create the right conditions and you surrender the outcome, right, is when you're going to get on the other side of this.
mm.
And that's easier said than done, as you know better than anyone.
Mm. Was there been, I mean, you mentioned before with some of your challenges with injury, has there been times when you thought, going through that OCD lesion when you were younger, that was it, that you weren't going to be getting back to what you were doing? And I guess when a surgeon tells you you're done, how was that, going through that experience yourself?
Yeah, I mean, it was a very upsetting
Mm,
situation. I mean, I was supposed to meet with a couple, in time, a couple collegiate tennis coaches, and I didn't understand the implications of that, and that doc, in hindsight, I almost wonder if he was having a bad day, but he
mm,
painted it in this very grim light. And then I was also in his office, which it almost felt like a morgue,
mm,
right? It was just sort of cold and clammy. And I remember him putting the x-ray up on the stereogram, and I was there with my mom, and he said that. And I just, I sort of
mm,
like started tearing up a little bit, but it
mm,
wasn't until I got home later that day where, I just sort of like had a meltdown.
mm,
Um, and in hindsight, I'm glad that I had that experience, even though it was tough to swallow, because it made me also realize you can't jump to conclusions. I ended up connecting with this world-class orthopedic surgeon, one of the best docs in the world, Freddie Fu.
mm,
And when I connected with him, it was just completely different
mm,
situation. I went into his office. He had frames of like probably 150 to 200 pro athletes around the waiting room. When I went to see him, he had basically a group of maybe 10 fellowship trained docs, PAs, just like he had a posse that came in with him. And he's like, Mr. Johnson, we will get you better and back to tennis. And it's like, that's all I needed to hear.
Yeah,
Um, so it also highlights just how powerful non-specific effects are,
yeah,
right?
yeah, yeah.
So
Yeah, it's certainly our actions, communications, body language, all those sort of things make a difference, don't they? That's when you said, whether he was having a bad day or not, but that unfortunately could have had a dramatic impact on yourself in terms of your
yeah.
recovery. But you talk about earning the right to run. So what does that mean in a practical sense for a runner to earn the right to run?
Yeah, well, I mean, I think anyone can go out and try running. I mean, if you're coming back from an injury,
Mm,
people fall under the notion that, hey, once pain is gone and maybe swelling is resolved, that they're good, right? And I see this a lot with people following lateral ankle sprains, and I fully support that. I think that's, an adaptive behavior, which I like to see, in contrast to someone who's very fearful or trepidatious or guarded. But I also think that we have a pretty good semblance of what the performance demands are of running. So we need to prepare people for those, and I just want people to check some very simple boxes, and a lot of this basically will, dovetail with the physical performance test, but I want someone to be able to get through 45 to 60 minutes of walking or
hmm
tolerant of, if we look at like the Tudor Lock and Bassett paper, that's stratified step count. I want someone to be active, 10K to 12.5K steps, no pushback with activities of daily living, and we need to be cognizant of what tissue we're dealing with too.
Yeah.
I'll give people with a lower limb tendinopathy a little bit more leeway. With bone stress injuries, I'm going to put some tighter guardrails on people.
Yeah.
But, the main thing that I want someone to be able to do is to directly load through that tissue or involved region, because I feel like if they can't do that, they're going to get exposed just because of the repetitious nature of running, especially road
Mm,
running, right?
yeah.
If you don't have the strength, the fatigue resistance, the coordination, you're going to get exposed, and it's just a matter of, making one hasty decision,
Mm.
or having a little bit more life load that you're having to contend with, and boom, you end up getting a setback. I want to try to safeguard against that because I don't want anything to interfere with them regaining confidence, and if
Mm.
they're trying to get out of the gates and they're stumbling, like it's probably telling you that you need to go back to the drawing board.
Yeah, and that's why I think it's also important to, I mean, when we talk about, discussing with our runners their training loads, I think it's also, important to talk about what they're doing on a day-to-day basis. Are they in a physical job? Are they doing 20,000 steps a day? And therefore, when we're bringing them back, I think it's really good that you mentioned, getting through that step count, getting through that activities of daily living, because if they're not doing that and then we're going, all right, off you go, let's run, and they're going to go back to doing those, increasing their daily steps, and that can be a double whammy for whatever injury that you're dealing with. So I think you bring a good point there of making sure that they are ready for life first before we start to pile on the training stress. And
Yeah, and
so yeah, sorry, you go.
well, I was just going to say, for clinicians who are listening to this, have your patients walk you through what their typical day looks like. I think people have daily habits. The weekend can be a little bit different, but generally, you want to find out, okay, what time did they go to sleep the night before? What was the quality of their sleep? When they wake up, what's their routine? Do they go downstairs and have a cup of coffee? Are they training first thing in the morning? Are they fueling before they train? Okay, they come back,
Mm,
do they have to rush off to work? Do they have kids that they're having to get ready for school? You really need to understand all the different loads and
mm,
you'll never get it perfect, but
no.
you want to have some semblance of what the requirements are of that person, physically, mentally, spiritually. And I think at that point you can start saying, okay, let's think about pulling X, Y, and Z lever. And I don't think people always have that conversation, and
Mm,
they're very quick to jump in and give advice, and I think that that tends to backfire.
Yeah, and that's what I think. I think I also find too that the mistake that clinicians do is they just focus purely on that running load and not so much the life load. And I think it was Pete Malliaris that taught me, it's what are you doing in your 23 other hours of the day? You might be running for 1 hour, but what's happening in your 23 when it comes to stress, sleep, work, life that can have an impact on these things, can't it?
Yeah, 1,000%.
And so in terms of then having criteria to achieve before getting back into running, so you mentioned, with the step count there, getting to that 45 to 60 minutes. Obviously this that it's tissue and injury specific, but maybe you could give just a couple of examples of some of the criteria that you might use for some different injuries and what they want to be ticking off before we start to think about running.
Yeah, so I think that in my Instagram bio, I have the battery of physical performance tests where if I can take someone through a comprehensive group of functional assessments, that's what I'm looking at. And they go from most conservative to least conservative. So, some of the key ones, can someone tolerate just balancing on one leg? Can they tolerate a lateral step down? How are they in terms of holding a star side plank, a long lever bridge, getting into pogo jumps and single leg hopping? I mean, ultimately, running is about elastic recoil. So that's why so many people look at single leg hopping to really determine, is this person ready to run? But I also will dance with those a little bit. People don't have to, pass all of them with flying colors. But if someone is coming off, say, a femoral neck bone stress injury or a femoral shaft bone stress injury, I want them to be able to load that hip every which way. I want them to be able to tolerate a star side plank, holding that for a slow 10-second count. I want them to be able to tolerate a long lever bridge, an adductor plank or Copenhagen plank. I want them to be able to tolerate pogo jumps for a minute in place, medial lateral, anterior, posterior, and then single leg hopping. Because if they can't do that, I feel like we're playing with fire if we
Mm.
try to introduce a return to running program. So um, yeah, and I think people lose a lot more capacity than they appreciate, especially with bone stress injuries, but with
Yeah.
other injuries as well. So you just want to have confidence because if that person goes to plug back into a return to running program and again, they stumble getting out of the gates, they're going to lose confidence in themselves. Their fear is going to ratchet up and they're going to lose confidence in you as a person guiding them or
Mm.
helping them navigate the situation. That's what we want to avoid. So that's why I'm always very conservative and I revel in process.
Yeah.
Um, so
And because again, setbacks can be quite distressing and I guess how do you deal with that? We're sort of going forward a little bit there, but whilst we're on that, with setbacks once we've returned to running, what are some things that you'll educate your runners about setbacks?
yeah, well, I normalize them to an extent.
Mm,
As much as I'm saying we want to try to avoid them, I say, look, we're putting guardrails on you, knowing that you're going to bump into the guardrail, right?
mm,
It's like when I take my son bowling, we have the bumper rails come up because we
mm.
know that he's going to hit them, and we don't want the ball to go in the gutter. He'll have a bad afternoon. Um, and I tell people just because you may get a little bit of pushback it doesn't mean you're going back to square one. So I
Mm,
think of a great example. So I was recovering from my first bone stress injury, a calcaneal bone stress injury, which is definitely, people say there's no place for the calf to hide. There is zero
mm,
place for the calcaneus to hide. And I was out on a place called Woodby Island, and I was doing a lot of my return to running on a treadmill. It's a little bit more forgiving, especially if you're talking about the tibia. But I was out running and I was over ground and I was on some cambered road, some incline, decline. And I got back to where the house we were staying. And I'm like, man, my foot's a little bit irritable. Like, and that was the first time that I had done a run of that duration, um, over ground as opposed to in a more controlled environment. So, I think that's a great example of bumping into the guardrail. Like my foot got a little bit
mm.
sensitized. Rather than sticking to an every other day schedule of running, I gave myself 2 days of reprieve,
Yeah.
right? So I think to just understand that people are going to go through those hiccups or bump into the
Mm,
guardrails, and it's just how you respond. And it's
mm,
never going to be perfect. It's just acknowledging the fact that in this case, my foot got sensitized. Okay, well, how do I get back into a good state? Well, pull back a little bit. Don't let your mind go maladaptive and start freaking
mm,
out, thinking like you're back to square one.
mm.
My foot got sensitized. Get some sleep, stay off your feet, bike the next 2 days, and then let's reassess. And when I do go back to run, I'm going to probably go on the treadmill and then I'll go back to over ground running and just keep it on level ground, not cambered surfaces, not inclines,
Yeah.
declines.
Are you ever preempting the runner? Are you ever sort of saying now you may experience this, and if so, these are some of the things that we would consider. Are you ever doing that with, warning them or just getting in their head to start to normalize it early on that things might happen, maybe not from a bone stress injury, but from a tendinopathy point of view.
Yeah, for tendinopathy, I mean,
Mm,
it's funny. With bone stress injuries, I'm always putting like pretty tight guardrails on
yeah,
people
yeah,
just
yeah.
because they really sideline you. With lower limb tendinopathy, I'm telling people, look, don't be stupid. Like just use good judgment, right? You're
Mm,
not going to do anything to tear the tendon,
mm,
where it's going to spontaneously rupture unless you're on a fluoroquinolone. And I tell people, not only is it okay, it's probably a good thing that you're having a little bit of discomfort, as much as they may not appreciate that at first. Um, so yeah, I'm much more cavalier with tendon, working with runners who have lower limb tendinopathy versus bone stress injuries because I feel like the implications of getting it wrong are a little bit less grave.
and
But I
with bones,
also,
yeah. Mm, no, you go.
well,
Yeah.
I also just want to say, like, I think it's important to understand who this person is in front of you. Is this someone who is very pain averse? Or
Mm.
is this someone like David Goggins who's going to just say fuck it and just throw caution to the
Yeah.
wind? Because
Yeah.
that's going to influence how I approach that conversation.
Yeah, definitely. The personalities will dictate yeah, how you, whether you crack the whip or pull the reins, as I frequently say. And
Yeah, it's a
uh,
great. I'll start using that.
yeah, and one of the things that I find challenging, with flare-ups and with bone stress injuries is sometimes the presence of pain. And it's sometimes, you think, well, actually, is this what's going on, or is this some phantom pain that they're feeling? Like, but I had it recently with someone with a femoral neck bone stress injury, and we'd seen her. We were due to re-image anyway for her, and she's like, oh, I still sort of feel this, this discomfort around, occasional discomfort around through here. And anyway, the imaging came back all perfectly clear, but I've certainly seen it with others as well too, and that. I think that can be challenging, can't it, for us as clinicians and the runner to tease with, well, is this, what's going on here? What your experiences with that?
Yeah, I mean they very much reflect what you just mentioned, and
Mm,
I think back to the NOI group with David
mm,
Butler, Lorimer Mosley,
yeah.
talking about neurotags, and I tell people, I've had 8 or 9 people dealing with navicular bone stress injuries recently,
Mm,
and sometimes people can have ongoing symptoms, and
mm,
but you don't know if it's like because their foot's
I
gotten
know.
deconditioned from being non-weight bearing. So, I tell people it's sort of like a tattoo. It's like once you have it, you can remove it, but there's always going to be a faint remnant, and you also have the experience of having gone through it, which is always going to be a part of your mind, right?
Mm,
Um, but I think that you have to look at the other physical performance tests. So if someone's like, "Yeah, I'm having some discomfort," I'm going to say, "Okay, can
mm,
you hold this side plank? Can
yeah.
we go through all those physical performance tests? Because as long as they can perform those and make the cut, then I'm
Mm,
like, let's continue to monitor. The other thing too, you have run easy,
mm,
and that's something that I think if you're working with someone who has a bone stress injury, because of the redundancy in our nervous system, that people can trick this stuff out. Our body is masterful at compensating. So
mm,
that's a case where I definitely want to have someone, if they're running, right, and it's 0 to 1 out of 10, I want to watch what they're doing. And hopefully you have a baseline, because
yeah.
if you don't, you have to be a little bit cautious in how you're interpreting the data. But you can have people that look fine through a qualitative analysis. And then I've seen this on numerous occasions. You put the run easy on them, and there's an avoidance strategy where they're
Yeah.
not going over to that side, or there's, some kind of compensated shock attenuation strategy.
Yeah.
Um, and I've seen that personally with my heel. Like I could run, people went to an
Mm,
untrained, even to a trained eye, you wouldn't know that anything was wrong, but you
mm.
can see it in the data. Like, so that's a tough system to cheat.
No, I've actually had a couple of more chronic tendinopathy patients recently, the Achilles tendinopathy that did exactly that on, and you could see them offloading that side. They just didn't want to, they're putting much more weight through their asymptomatic side. They just didn't have that. That have the confidence, or again, it's been an ingrained pattern there for so long that they just that's the way they run. So they've changed that, and you mentioned, having access to run easier. Are there other sort of other metrics that that you use that I guess as a coach, like when you're coaching your runners, there's lots of things that you can use from that. Is there things that you'll look to track from, as your runners getting back to running?
Um, I look at a lot of data. It depends on what the
Mm,
person is interested in collecting. So I recently helped a pro triathlete who's rebounding from a tibial bone stress injury. So he collects, the beauty of working with the pros is they collect everything under the sun.
mm,
And they're also willing to roll the dice a little bit more, where they're like, hey, I'm going to do this race. You may not think that I should be doing it, but, I have sponsors and this is my livelihood. And I'm like, okay, let's just keep tabs on things. So because they track everything under the sun, I may look at power. You have to be careful with power because there's a lot of modeling that's done. But I'm going to look at whatever data that I have access to, especially with
mm,
athletes where I've been privy to their data prior to the injury.
yeah.
So I'm sort of like saying, okay, this is what was going on before they got injured when they were training healthy, and this is where they started going south. So yeah, but you may not always have the ability to, tap data like that, right?
Mm,
So I think that's when you want to pick up the phone and engage people in
yeah.
conversation
Yeah.
to see how they're feeling. Did they feel like they were adopting altered mechanics, or what's their gut telling them?
Do you think that having, I mean, with the rise of wearables and all the things that we can track, do you think that will help to give us some potential answers and in that, in terms of, warning a preceding injury, or as part of, I guess, as part of rehabilitation?
Yes and no, right? I don't think
Like to say
data is ever
yes,
going to
we're
give
gonna
us.
solve we're gonna solve
Yeah.
everything and solve all the world's problems. Damn.
Well, I think we learned from the classic paper from Emily Matevich. I don't know if I'm pronouncing her name right, and Carl Zellick. I mean, a lot of the wearable technology, they were using the wrong surrogates,
Mm,
and um, for example, like they were talking about, ground reaction force and impact
mm,
metrics, and that didn't remotely capture what the tibial bone was seeing, more from the
yeah.
contractile forces of the calf. So I'm always wary of this. That's why I do like the Run Easy device. And I
Hmm.
don't want to sit here and like plug them too hard, but
Proudly sponsored by
because they did
Run
a lot of,
Easy. No.
well, they did
Yeah,
they did a
yeah,
lot of validation work. And
yeah.
when I find that I can't trick out a system, I'm going to put a
Mm,
little bit more stock in it.
yeah.
But the problem is most people don't have Run Easy if they're an athlete. A lot of
Mm.
clinicians may. So, I think you're having to really lean heavily into communication with the athlete,
And that's
and
a,
the
yeah.
trick,
Mm.
go
Yeah.
ahead.
Oh no, I was going to say the issue with again some of the data that is collected is, yeah, the accuracy of it, the validity and the reliability of what we're getting. If we're getting something from a chest rates, a Garmin chest straps, like, how accurate is that if it's trying to measure what's happening at the feet through there? So there's questions on that too, isn't there? The validity of it, what we're getting.
Yeah, for sure. And I think the most challenging thing, especially with bone stress injuries, is runners are very reluctant to acknowledge their symptoms because they're in denial a lot of the times, so, and then you have athletes who aren't acknowledging their symptoms and they know something's off, and then they may, punt on connecting with a clinician, and then a clinician may not have a bone stress injury on their radar, or it may be warming up, which really throws them down the wrong path of clinical
Mm.
reasoning. So that's why I put so much stock in communication, because I feel like the faster we can identify them, the faster we can get them to do a U-turn.
Yeah, yeah, absolutely. And so with the with we've done gone through our tests, we've cleared them to run. What is your then general structure when it comes to sending them back, whether that be, with frequency or duration and intensity? So what's your sort of guidelines for that?
Yeah, so my early goal is with any athlete I'm working with. I almost don't care the sport. I mean, we'll stick with running and triathlon, is to reestablish consistency of training. To hopefully avoid or minimize detraining during that time, but to reestablish consistency of training. Because if we can't get that dialed in,
Mm,
um, they're not going in the right direction, and we've probably preemptively plugged them into a return to run. And you have to prepare people, because I say, hey, what do you think is sensible in terms of starting a return to run? They're like, oh, I'll go out for like a 20 to 30 minute run, and I'm like, definitely not, right? I'm saying, look,
wrong.
1 minute run, 4 minute walk. Let's repeat that five more times, or six in total, for 30 minutes. And, if someone is dealing with a high risk bone stress injury or a recurrent bone stress injury, I want someone to prove tolerance to that level 3 times. So if it's Monday, Wednesday, Friday, and then we would go to a 2 minute run to a 3 minute walk. And then we're tinkering with that 5 minute ratio. Um, I feel like those first 6 to 8 weeks are critical, and that's
Mm,
that's the most volatile time.
mm,
That, as well as when you introduce intensity, whether that's through hill work, but mainly running fast.
yep.
Um, so I'm pretty strict with just being conservative during those first 6 to 8 weeks, and then once I feel like people have their ducks in a row, I may nudge a little bit. But what I don't want is to prolong their recovery any longer than they've already been out.
Yeah. And with that, you mentioned then eventually getting to intensity. What are some of the things that you want to achieve from a running point of view before you introduce that intensity? And what does that look like at that first, that first time that they're going out, and it's a full throttle, open the gates and do a 5K time trial, or
Yeah, definitely not.
oh
I
damn.
would say, yeah. So I want someone to be able to run an hour at conversation pace on rolling terrain, right?
Yeah.
From there, then I may say, hey, let's have you work in maybe a couple 2 to 3 minute just tempo efforts. Don't beat yourself up. There's no perfect. I think that, strides can be introduced, but understand, strides are going to run faster. You have to hit the
Yeah.
ground harder. There's greater contractile forces. So, in the context of someone coming off of a bone stress injury, I'm going to just, again, throw them softballs. So if I say, hey, let's have you do a 5 minute run at 3 out of 10 RPE, very easy, a 10 minute run at, 3 to 4 out of 10 RPE, so like below that first ventilatory threshold. Let's just do maybe two 3 by 3 minute intervals at a 5 to 6 out of 10 RPE. Keep that on level ground, and then just have them do an easy 10 minute run to cool down. So when you go to introduce intensity, I think of all of this as band equalizers on like an old school radio. If you're going to turn up one dial, you got to turn down another. So if
Mm,
I'm going to introduce intensity, I'm shortening the duration of that workout, right?
yeah.
And there's just got to be some simple heuristics that you're following, and that would be 1 day a week. So, if they prove tolerance to that week one, say if again that 5 minute run at 3 out of 10, 10 minute run at 3 to 4 out of 10, week one, 2 by 3 minute intervals at 5 to 6 out of 10 on 3 minute jog recovery, 10 minute easy run, 5 minute walk cool down. Week two, all I'm going to do is extend that one additional bout. So rather than 2 by 3 minute intervals, 3 by 3 minute intervals.
Yeah.
Maybe the third week we go to 4 by 3 minute intervals, and then we do a deload week, right? So I always use this term nudging, and people
Hmm.
really, I think that resonates with them.
Yeah.
But you're just sort of pushing their fitness up and the intensity up from the cellar, trying to bring it to the first floor and then to the second floor and then maybe to the attic.
Yeah, yeah, yeah. No, that makes complete sense. And then in terms of then with elevation and hills, what are your sort of thoughts on that? When we're taking that into consideration, we're taking speed into consideration. What are we sort of what lever are we going to be pulling when?
Yeah, so I always say running fast comes last. So I'm much more
I
willing
like that one.
yeah, I'm much more willing to introduce some hillier terrain before I get people at the track, sort of opening up the throttle.
Yeah,
I don't know if it was Vernio or Bagley that, they did a study and they basically, I think this was 2 years ago, and they basically said that we used to think intensity, for example, hills were creating a much greater stimulus on the calf, and we needed to be sort of trepidatious or cautious about that in the context of a tibial bone stress injury. But through that study, they showed it was really intensity and speed of
mm,
running that was a
yeah,
key factor. So, I would be much more likely to put someone out on, a hillier run before I
mm.
start having them open the throttle at a track or doing some really hard intervals.
Do you use instead of doing strides and or efforts on the flat on the hills and what would you choose over one or the other? Would you early in the process would you say, all right, we're going to do some faster if it's on the hills versus the flats, or what's your philosophy on that?
My gut with that, and there's some studies that have broached that conversation, but I would, I don't want to pull two levers at the same
Mm,
time. So if I'm going to
yeah,
have someone go run hills, I want them to run hills at conversation pace.
yeah,
You know, I don't want to turn the speed or velocity dial up at the same time as they're doing hills. So, but the end goal would be, I mean, you look at something like the Helgerud study, which is 4 by 4 minutes, you know, um, and I believe that was at a 4% grade. The goal is to get someone back to doing efforts like that, because at that point I have the confidence that the adequate healing has taken place. Not to say you're completely in the clear, but at that point they're starting to get back to training as they as they see fit.
yeah. And with the run walk progressions, things that runners and clinicians make wrong with that where they can go astray with a run walk. What are some of the things that, apart from not doing it, but what else do you
Mhm.
see them? What else do you see them doing wrong with that?
Well, I think the main thing is not doing it, right? So, my one of my early goals with any runner is to get them up to, an hour of
Yeah, okay.
running, and that could be
Yeah.
that could be broken. So, I work with a woman who is postpartum, and rather than rushing her back to an hour of continuous running, where her form's likely to break down, her cadence starts to get slower, she has a history of patellofemoral pain. That's what I want to avoid. So, I may start off saying, hey, let's have you do week one, 6 by 10 minute bouts of running on 1 minute walk. Week two, maybe we go to 5 by 12. Week three, 4 by 15. Week four, 3 by 20, right? You can skin that cat so many different ways. And
Mm,
it's mind blowing because people have never seen programming like this, but all they
yeah.
know is that their runs are more enjoyable.
Mm,
They're able to break it up into chunks so it's easier to wrap your head around
mm,
psychologically.
mm.
And I think it's also a great way, especially with longer runs, to get your fueling in where you're not rushing.
Yeah, yeah, that's it. That's certainly a big one, isn't it? But yeah, I've actually found some runners that have quite enjoyed the process. They're like, no, I quite like the occasional walk break. It gives them a reason. Like sometimes when you're running around, you see the traffic lights, and you kind of actually want it to go red so that you can have a bit of a rest. So it's
Hmm.
sort of giving them a reason to do that, isn't it?
And you can tinker with, say if someone goes through that progression, then you could bring them back depending on what their goals are to say, hey, let's have you go back to 6 by 10 minute bouts. And I want you to slightly negative split each one and
Mm,
just repeat that, like nudging. Like, how do you, because I mean, there's a big study that just came out that, it shows when people don't nudge, especially with the long run, that, that's where they get into trouble if they really jump that 10% above, their previous long run in the last month. I wish they would have just taken that
mm,
study and, taken that run and just turned it into a 2 a day, where rather
mm,
than do it all at once,
mm.
someone did half in the morning, half in the late afternoon.
Yeah,
But
yeah. And with returning to running and pain. So, we had one question submitted. What is acceptable? And obviously that can be different from injury, but what's your take on acceptable levels of pain?
it's another great opportunity to lean into that conversation with someone, to say, hey, what we know is we don't need to wait for 0 out of 10 to be present for you to plug in if we're talking about a lower limb tendinopathy. So,
Yeah.
you know, um, if I give you a numeric number, I mean, we can pull on the pain monitoring model, originally developed by Tomei, that Karin Sobernagel and Kay Crossley popularized. But to say, we're cool with even up to like 4 to 5 out of 10 pain, but I want to know what's acceptable to you, right? And I think that's an important question. It just gets people reflecting on it rather than, because I think a lot of times people have a tough time saying what 4 to 5 is.
Mm,
I had an Achilles tendinopathy, and it was reactive. It was swollen. I was trying to hold on to fitness for a fall Ironman, and I was riding around Seattle, and it was like 7 out of 10 pain. If I had to give it a numeric pain rating score, I'm a wimp around pain. Anytime someone's like, "Yeah, I have a high threshold for pain," I'm like, "Bullshit," you
mm.
know. Um, so, but I knew because there was no energy storage and release, and I wasn't altering my mechanics. It was uncomfortable. That I knew I probably wasn't really harming the tendon, right? So I think that the main thing you want to make runners cognizant of is if you start sensing altered mechanics, right? Which some people are a little bit more in tune with their body than others, but um, I want them to pull the plug on
Mm.
that and to really be honest with themselves. I mean, do you feel like you're going in the right direction, or do you feel like you're moving further away from the destination?
Yeah, and I think that's good as well too, and it's that joint decision making, isn't it? You're not just telling them do this, do this, do this. It's like, well, how does that feel? Do you feel like that's acceptable? And again, so getting their input is really important, isn't it? Having that communication. and and
Yeah.
and with in terms of then modifying that return to running for different injuries. So, how does that return to running differ from a tendinopathy versus a bone stress injury?
Yeah, so I think that we need to be much more vigilant in terms of working with people who have bone stress injuries. So it's like if you tell a runner 1 out of 10, they're gonna basically 2 to 3.
Hmm.
So I do think that you want them to understand the implications, that you don't want to stir up that bone chemically or mechanically. Um, I always want to know with lower limb tendinopathy, having dealt with a lot of lower limb tendinopathy, you know, how does it behave during the training session? How does it behave the rest of the day? And then obviously the following morning. Um, I never want to shut a runner down. I've trained through a lot of races where I've had some of my best races in the context of a lower limb tendinopathy. But, I always was able to keep myself on the right side of the fence, so the main one that I dealt with was patellar tendinopathy, which
Hmm.
I think a lot of clinicians don't realize that in runners it hits that anterior lateral tibial tubercle. Um, so I always knew that if I had a lot of pain sitting with my knee flex, kind of the way I am right now,
Mm-hmm.
that that was always a good litmus test in terms of how stirred up it was,
Yeah.
how it felt, um, when I would go into a session, if it would warm up, how shoes affected it. So I think that the implications of getting things wrong with a lower limb tendinopathy are less grave relative to a bone stress injury.
Yeah.
Um, but it all depends. I was teaching a course this weekend in Wenatchee, which is like 2.5 hours away from Seattle, and this woman came in who's dealing with a proximal hamstring tendinopathy, and that's a great example of someone you definitely don't need to shut down running because with her being more of a distance runner, she's really biasing the forces to below the knee, right? So I feel like in cases like that, you can do things to shield the tendon a little bit more. So obviously, speed, keeping her away from uphill running, keeping her away from activities like erging or orange theory, which tend to introduce a lot of compressive forces. I feel like you can do things to shift the forces, knowing you can't magically make forces disappear. Um,
Mm.
I think that's a little bit trickier with bone stress injuries.
Mm. And what about in terms of you mentioned before about splitting up runs and what do your in terms of different conditions you find will respond to double runs or running on adjacent days? How does the injury affect the frequency of the runs that you prescribe?
Yeah, that's a good question. How does the injury affect the frequency? I'm trying to think of a case that may highlight that. I think that you have to understand how bone and tendon respond to load.
Mm.
And, a lot of this stuff, is obviously based on animal studies or military. So, there are some limitations. Um, but yeah, I mean, I think in the context of, and I want to make sure I'm answering this question because I feel like I'm
Mm.
going to get off topic, but um, yeah, I tend to prioritize shorter runs a little bit more frequently with a lot of people. I think a
Yeah.
lot of distance runners are so enamored by the long run, and a lot of it is negative chatter because they hear other people talking about the long run. And, I feel like once you start running, especially like 90 minutes, but 2+ hours, you have to be really cognizant about what you're doing on the front and tail end of that run, right? So most of the time, I'm having people run, even competitive runners, like an hour, right? And I'll have them do a long run at some point during the week, but that long run is not like 3 hours. It tends to be a little bit shorter in duration. Um, but I don't know if I'm answering your question.
Yeah, I think like in terms of and whether that's tendinopathies that may not handle back-to-back days. So running on a Monday and a Tuesday, they might need that non-running day in between, or whether with bone, whether you might be able to run that Monday, Tuesday, it might be better tolerated there. Is there sort of things that you've found in regards to that?
Yeah, so I think that a good way of conceptualizing this is people talk a lot about, frequency, duration,
Mm,
intensity. And, I think that the missing um, D is density, right? So,
mm,
anytime you're getting back, helping someone get back to running or reclaiming consistency of training, run them non-consecutive days, even if they think they can handle more.
yeah.
So Monday, Wednesday, Friday, Sunday, right? And then at some point, I will go. So if someone gets back to an hour of continuous running, I may have them start to go back to back. So it'd be Monday, Wednesday, Thursday, Saturday, maybe Saturday, Sunday, right?
Mm,
So you're putting those workouts a little bit closer together, but still saying rather than 48 hours of reprieve to say, hey, I want a strict 24 hours because
yeah.
we're going to be going back to back. I want to still keep a little bit of a guardrail on you there. So, and then you could even take density one more level or notch it up where you're having someone run maybe late afternoon on a Tuesday and then turning around and then running maybe Wednesday morning,
Yeah.
right? So that's another very simple way to nudge things. But yeah, I find with a lot of runners, there's a woman who I coach who's going to be doing a marathon this upcoming weekend, and for a variety of reasons, I don't have her just go out and do the Sunday long run where she's going to go out for. I mean, she wanted to work up to like 3.5 hours, and I said, let's just split it up. Do a
Mm,
run in the morning, you know, come back, get some food, and you take a nap. and then maybe mid-afternoon go out again, right? So that way we're getting the volume, but it's
Mm,
not all in one fell swoop.
yeah.
I feel like that. I just, having done a lot of long runs, I just feel like, I go to the well and it takes me 2, sometimes 3 days to recover, especially if I'm doing any kind of
Mm.
intensity or tempo work.
Is there just in terms of that, there's a bit of an aside, like splitting up that run because it's something I have implemented before with my runners. Is there probably is there a thing that they miss out on in terms of by doing that, they're not getting maybe the fatigue resistance later on in the run? Like you probably wouldn't want to do that every week, would you, in terms of splitting that up because you want them to develop the conditioning and the durability to last that, that 2, 3 hours on their feet. Would that be right? Would you?
Yeah, I mean, I think for a mental confidence
Yeah,
standpoint,
yeah.
that so I do end up blending. So with this woman, I got her up to running 15 miles continuously, but she ended up doing an 18-mile run that we split into two. So I'm staggering it. So
Mm,
it's not just all double workouts, and I'm not talking about threshold here for people who are listening. That's a
yeah,
different beast.
yeah.
Um, but yeah, so for her, I would stagger weekends, right? And the other thing was, that's tricky is she's doing the Las Vegas Marathon, which is something
Mm.
crazy. I think it's like they switched the course and it has some gnarly elevation loss. So it's pretty much a downhill run. So the challenge was with her was to get 3 runs in prior to that, where she's running down a 6 to 7.5% decline slope,
Oof.
right? Yeah, just so we
My
can
quads,
sort of leverage the
my,
repeated bout effect.
my
Yeah.
quads are hurting just thinking
Um,
about that. They're
yeah.
scarred. They're
Yeah.
scarred after Sydney Marathon a couple of months back was there was a lot of down in that. The hilliest out of all the majors now. So my quads were pretty torched the week after that.
hmm
It's,
Rich did a great post on that. Just talking about soreness. When I say Rich, Montana Running
yeah,
Lab. So if you just
it's
search
really
that, I think it's one of his more recent posts. But one of my mentors was Mal McHugh, who, I mean, he's one of the world authorities on muscle damage. So I got exposed to the repeated bout effect numerous occasions
mm.
because I felt indebted to him. So I would always volunteer to be a subject in all these muscle damage studies. And a lot of them were, on the shoulder as well as the quad. And I remember, like, after going through those protocols, I'd be going around New York City, like couldn't raise my arm, walking with a
You
hitch
know,
in my giddy up.
you know all those
Yeah,
studies that have involved some poor students, most of them that have been roped into to participate in those, don't you?
that
But
was me.
now with the we've got our runner back and we've started on that return to run process and what are some of the things that we would consider whether we push them a bit quicker or whether we hold back a bit more? So some factors that you're using to make that decision.
Yeah, so I mean, I want to consider, is this a first time occurrence? What's the tissue that's involved? And then I want to really make sure that I understand their allostatic load. If I get the sense that people have, a lot of crazy moving parts going on in life, I tend to be much more conservative because I feel like it takes less to tip the scales. If I'm working with someone who is, say, early 30s, they're a bachelor, like I have a couple of people I work with who are like very bought into wellness and longevity, and they
Mm.
take much better care of themselves than I did at that age.
Mm.
That I'm saying this person has their ducks in a row. Let's nudge a little bit more. Again, assuming that we're not dealing with a bone stress injury. I never get aggressive. Um, or try to fast track people,
Yeah.
unless they're saying I'm going to do this anyway. I want you to make sure that I'm not totally dumb.
Mm.
Um, so it's understanding, when that person is left to their own devices, how do they operate in the first place? And then what's the allostatic load that they're dealing with?
Yeah.
I have a fellow that I'm thinking of right now, and, he was recovering from some tibial bone pain, and he had lost his job, right? That's not someone who I'm going to be cavalier with, right? I'm
Mm.
going to just say, let's just very patiently work through this because he's probably dealing with a lot of other stress and
Mm.
fears and anxieties around that, because he's in a sector where AI is gobbling up a lot of these jobs. Um, you just have to be cognizant of that stuff. You can't just look at this purely through this is the injury, these are the expected recovery timelines. They're going to follow, or fall right into them. Um, so it's getting to know the person. Back to that.
Yeah, yeah. And you mentioned before about that having that deload week. Now, is that something that you'll put into place, regardless of whether you're, doing that run walk, and if so, how often or how frequent you're putting that deload week in?
Yeah, I just finished some half marathon programs and I put the deload week after, so there's a 4 week block and
Yeah.
then week 5 is a deload week, another 4 week block and then another deload week. And it's an 18 week program. I didn't put a final deload week in
Mm.
because, there's sort of, approaching the taper.
Yeah.
But I also think that, life has a funny way of, sort of determining your training if
Mm.
you're cognizant of it. So a great example is I have an athlete who's going to be racing 70.3 worlds in terms of triathlon. And, this upcoming weekend, he has to go to his grandma's funeral, so when his grandma passed, that was about 6 weeks ago. I just said, dude, just this week unstructured, no crazy intensity. If you can train for, 45 to 75 minutes a day, awesome. Just, zero stress, right? And I'll give him another deload week, or like a 5 day block where I'm just shortening the duration of those workouts. I may keep a little bit of intensity in, whether it's strides or some intervals on the bike, but I think sometimes life will tell you when that deload needs to
Yeah.
happen. And if it doesn't, I'll generally have people, if we're in a base building phase, maybe I'll go 5 weeks if it's less intensity and more volume.
Yeah.
If we're focusing a little bit more on intensity, trying to sharpen the knife, maybe I'll do a 3 to 4 week
Yeah.
block and then deload them. So it's highly specific to the individual and in their lifestyle and use stressors, distressors.
Do you prescribe? I don't know who it was that originally said it, but having that skeletal deload. I don't know whether it was Rich, where you have those with bone stress injuries and maybe recurrent bone stress injuries having a sort of a skeletal reset, a regular skeletal reset. Is that something that you use? And if so, how do you get the runner to
Uh,
buy into that?
yeah, I think they talked about. I think Stu Ward and Rich talked about that in
Yeah,
the
I
in
think that
the
was who it
paper
was.
and in
Yeah.
core.
Mm,
I think that's a good idea. I think
mm,
that's something that, if people run themselves amok, the question is what really engendered that? Was it a fueling
mm,
issue? Was it improper training?
mm.
Um, but I think it's just good to introduce that notion to say push, 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 let your body recover and soak up. Like I'll use the term, I want you to let your body soak up the training. What do you think about that? Where would you put the deload week?
Mm. Mm.
Um, but I think that's important, especially with someone who does have a history of bone stress injuries.
Yeah, yeah. Well, we've got 100 other questions that I could be asking at you, but I'm very mindful of your time. So if we head towards the final stretch, so few tips. If we give our 3 tips for runners for their running recovery, what would your 3 tips be for a runner listening to this? And then we'll go into health professionals.
Yeah, I'm grinning. I made a couple notes
Better not be
on
any more
this
than
one.
three,
So
or I'll cut you out if it's more than three. No.
yeah, so I would say that recovery is a game of addition by subtraction.
Mm,
Stop doing a bunch of shit, right?
okay.
When I try and get athletes to conceptualize what recovery is, to me, it may be watching a comedy, right? It could be hanging out with friends. It could be, doing some, box breathing. So these are all things that I think people just have a tough time sitting still. So as Dan John would say, recovery is simple. It's not easy, right? But I would say, what's
Mm,
rejuvenating for you? What's rejuvenating for me is hanging out with my kids, shutting my, shutting my laptop down, powering my phone off. I love walking around the neighborhood with my wife and Lulu, just talking about life and the state of things. So, but I would ask that person, what do you find, sort of is soothing for your soul?
Mm.
And then you're customizing it,
Hmm.
right?
Like it. That's one. What have we got? What have we
Yeah.
got? Two and three.
Okay, so the three tips for runners for their
Yeah.
running recovery. So one is game
What?
addition by
Yeah.
subtraction.
Yeah.
Two,
Oh,
it's
yeah.
it's
Yeah. Stop
simple,
doing
not
shit. Okay.
not easy.
Yeah.
And then three is reading, hanging out with friends.
Ah, awesome.
Um,
Okay. Gotcha.
you know,
Gotcha. Gotcha. But
yeah.
and then so then we move on to the health professionals. So what have we got for the health professionals out there?
In terms of when it
Re
comes to returning from yeah,
yes. Yeah. Yeah. Yeah.
so Luke had posed to me three tips for health professionals working with runners when it comes to returning a runner from injury.
Yeah.
Um, you ultimately need to blend the science with the humanities, right? I feel like a lot of the questions, that I have, the science, it's out there. If you want to dig and really comb through the literature, it's wild what people publish on. But I also feel like a lot of these runners are going through an existential crisis and an identity crisis. So you need to be well versed in the humanities, which is people are probably laughing who know me because that's why I post a lot of these quotes.
Mm,
I put up that Instagram post talking about the four screens. And, for people who haven't seen that, these are four screens or like quadrants of a whiteboard, which is, the first one is who are you? Actually, what are you? Right. So, if I had to answer that question, I'd say, oh, well, yeah, I'm a runner. I'm a lifelong athlete, but, I'm a husband, I'm a father, I'm a brother, I'm an entrepreneur, I'm a writer, I'm a creative person, right? I'm a son, right? So I have a lot of different identities. It's not just
mm,
running. The other screens are what are your fears and anxieties or constraints? What are the things that you have working for you? How have you navigated similar situations in the past that give you confidence that you can get on the other side of this? And I think a big one is in terms of the four is points of truth. So what do I mean by that? Well, if we have someone who has a bone stress injury, we need to agree on the points of truth. So what are those? Okay, this was a gradual onset. We have blood work that shows that you have deficits or you're out of the normal range in these areas. Um, right now, walking is painful. You can't single leg hop and anything else that ties into the equation, because if we can't agree on those points of truth, I have reservations about my ability to help that person because they're not acknowledging their situation. um, and I would say another tip for health professionals is people come to you and they sort of bring their problems, right? And the thing you have to exercise caution in doing is providing advice or swooping in to provide some mystical magical fix when you have no effing clue what's going on with this person. I tell people, I say, look, I'm glad we're here. I just want to start by saying I looked at your intake form, but I am totally ignorant to your situation. So where do we start?
mm,
And people, they know at that point that they're with the right person because you're not pretending to have the answers. People are not dumb. They pick up on this
mm,
stuff immediately. So, and tell people, say, look, this is, these are the things I don't have 100% clarity on. This is what I'm thinking. This is what my gut is telling me. I would say that's a third tip is like, what's your gut telling you?
yeah.
Right. To really trust that as clinicians, we have this sixth sense and we don't lean into it enough. Like, and sometimes Nathan and I were talking about this on the podcast. That could come in a visceral sensation. That could come in the form of an image. Um, that could come in the form of like a color, right? Trust that and never ever worry about being wrong, right? Because a lot of times you're gonna find out that it's pretty spot on. People be like, "That's so crazy that you just said that to me, because that's the exact image that I'm thinking about as I'm navigating the situation. Um, but I think above all else, and I think what makes you special, Luke, I'm going to stroke your ego a little bit, is you give off very positive vibes, and you also have this non-anxious presence where people are just going to sort of like, you probably don't even realize, maybe you realize this is happening, but just being in your presence has a therapeutic effect, and it allows people's nervous system to downregulate, and that's what initiates healing.
Hmm. Yeah, that's really good tips there, and you've mentioned a few times throughout, but obviously your Instagram profile is a wealth of knowledge. Now to bring us home, we've got our rapid fire round, so I'm going to fire four quick questions at you, and let's get some quick answers. So firstly, your favorite strength exercise. You can only pick one. It's your favorite child.
Yeah.
What's your favorite strength exercise?
Ugh. I'm gonna go with Old Faithful. I would say, putting plyometrics aside, I would say a farmer march. I
A
think
farmer march.
that is
Okay.
just, yeah, a loaded carry, but a march. And the only thing I'll say that, that doesn't really check the box of is you're not landing on a flex knee. So if you wanted to do it landing with a flex knee, maybe that would have a little bit more salience to running. I put down split squat and obviously a calf raise. I'll show the calf raise that I love to teach people later, but
Oh, I'm disappointed. That's what I was waiting for. No, that's
yeah,
I know what I'd say. But no, that's awesome. Then I know Dan John's a fan of the carry, isn't he? That's the weighted carries. They are underrated exercise, aren't they? The
yep.
carries. Most underrated rehab tools. So bring us onto that. I know you've got a few things that you use, but what's one of the most underrated tools?
Well, I would say back to what I just mentioned about you having a non-anxious presence, and
Okay.
you know, um, level three listening, where when you're working with someone, that I see a lot of clinicians who I know, they're like, oh, I need to make sure I'm on time for my next patient. Oh, I need to
Mm,
get this note done. People pick that up like
mm,
you're creating a strike against you. You want to be so present with that person because no one has ever done that,
yeah.
and that's when I feel like the therapeutic process ensues.
Hmm.
um and I would say, not to sound cheesy, but love, acceptance,
Hmm.
forgiveness. Like, I think that's a way out when people, um, I always find myself telling you, give yourself grace. You're going through a lot. We're gonna get this right. Just be patient. Let's think about what's the silver lining. And you may not want to hear that right now, but you're going to come out the other side of this a much more stronger, robust athlete. And we're going to get you back to running, but you're going to learn
Mm.
things about yourself that you didn't realize.
Awesome answer. A myth then something I didn't actually think of when I was asking that question. I thought, oh yeah, it's got to be some sort of tool, but I love that. A myth that you wish would disappear from running. So there's lots out there. What's your one pet peeve when you hear it? Your eyes roll back. There's a few out
Well,
there.
yeah, I'll say this: running is what got me out of a, a couple different knee issues. So I started off saying I had this OCD lesion. And I was dabbling in a lot of different multi-sport stuff, but mainly tennis. And when I started focusing on running as well as cycling, but a lot of my knee issues fell by the wayside. So you had posted about the physician who in New York City was telling people he's a plastic
Oh
surgeon,
God,
not
I
an
know.
MSK
Oh
doc.
God.
And I still need to do a post on this, but the timing
Yeah.
is off at this stage. But you know, this idea that running is basically going to lead to early onset arthritis is such
Mm,
bullshit.
mm,
And but the kicker now, granted, like competitive runners may show a slightly higher incidence, but the kicker of that is that doc then went on to say, whose office is on Park Avenue in the heart of New
mm.
York City, that you should go ride a bike. I've almost been killed twice in New York, near death experiences, and I fractured my clavicle in Prospect Park.
Oh,
If you're
how's
telling
that
someone to
way?
ride a bike in New York City, you need to have your head examined.
Oh no, it's
Yeah,
well that was actually the catalyst for this whole podcast. Episode one was was exactly that. This plastic surgeon. So yeah, I'm glad
yeah,
you agree with that one too. And then
yeah.
last sort of rapid fire question here. Best advice for clinicians wanting to work more with runners, and I'd throw an aside apart from joining your runner zone, which we'll mention in a second. That's the awesome community which you've built. But best advice for
Yeah.
clinicians wanting to work with runners.
Um, yeah, I would say let go of your pride and your yearning to be right.
Hmm.
Right. I think that, and you also need to, I think, immerse yourself in this community. You want to hear people's, their beliefs and thoughts. Like when I was, when I had a go at Runwell, which is a company that I've since dissolved with my friend Michael Henry, it was so amazing. We did a ton of user interviews. People are so fearful that they're just one step away from some catastrophic injury related to running. And, I think that we need a lot of clinicians to remind people that running is a very healthy activity. And yeah, there's a high incidence of running related injuries over the course of a year. Um, but, to reassure them that they're going to be okay, take care of yourself, be sensible with your training, but to keep leaning into conversations with them.
Mm,
I think that's really important and stop with the need to keep trying to do things to people.
mm,
I think that just backfires. The code of running is simplicity, right?
mm.
So, that should be a theme throughout everything that we do.
Well, Chris, that's been fantastic. It as I'm always doing, always learning from yourself. So I've learned many things today, scribbling down notes as we're talking through, and I'll sure I'll be listening back on this podcast, not to hear my voice, but to listen to you again. But for our listeners that want to learn more about you and follow you that haven't heard of you, where's the best place to find you, Chris?
Best place is my website, chrisjohnsonpt.com. For people who are wanting to learn a little bit more about my thoughts or approach, which is nothing mystical, magical. My newsletter. I try to focus a lot of time and energy on that. And then Instagram for me is acts of service. I wish I could give away all of my followers because I value everyone who follows me, but I feel like I'm in a good position at this point in my life to share a lot of my learnings. Like I said, I'm still on the journey as we all are. But I've also had a lot of, realizations and, refined thoughts about working with runners. So I try to, take all that stuff and just put it out for free. So it's almost like a Con Ed
Mm,
course if you just sort of comb through it and process. Read the captions too.
mm.
Hopefully they'll remove the character limits to some extent. But
Yeah.
yeah, I have fun with my Instagram.
Yeah, it's a great resource for everyone that goes to check out Chris on Instagram and obviously the Runner Zone community as well that you've built and the courses that you teach as well too. So look up Chris through the website and what's next for you, Chris? What's coming up? Anything exciting? Courses, teaching, always going on.
Yeah, that's a good question. I'm working. I'm not supposed to ever say what I'm working on,
Ah,
but yeah, I have. The universe is calling on me to put together, a coaching companion course, which I'll do
very nice.
with my buddy Joel Satgast,
Hmm.
where we talk about, yeah, programming, but really, how do you initiate work with an athlete,
Hmm.
from the onboarding process to, helping them, if it's reached the pointy end of sharp, if they have a competitive slant, or, to work to whatever their goals are. So, but yeah, I think a lot of this stuff is going to end up in
Hmm.
some kind of people when they say, who are you? I'm like, I don't know, maybe like a
I don't know
philosopher
anymore.
poet related to physical therapy.
Yeah.
So yeah, coaching
Awesome.
course, and at some point, I feel like Seattle needs they need a running centric clinic. I don't feel like there's a great one, and it's something that I have to wrap my head around because that
Mm,
that means going like all in on that business. But I don't know if that's something I'll do. I like to try and share a lot of my learnings with people
mm. It's
digitally
hard.
now, but with the tech, I mean, doing stuff like this is I'm very passionate about.
Yeah, well, I'm very appreciative of your time, Chris. You've been very generous today, and as I said, there's been plenty of key learning. So thanks again for joining us. Thank you to all our listeners, and look forward to catching up on our future episodes of the Rehab Runway. Thanks very much, Chris.
Thanks, Luke. Wish you the best of luck.
Thank you.